how do we give our meds? NBRC will have like one random question, two random questions related to this. The one they like to focus on is DPI. How do you give a DPI? What makes that one different than the other ones?
They're supposed to have a med of at least -50.
Yeah, they don't get that specific, but they want to know that the patient has to take the breath in deep and fast. Where the other one's slow, deep breath in. With the breath hold, this one's deep and fast. And what else? Oh, and never blow into the device. That's another random question that comes up.
Do we have a, sorry, do we have this?
You do. I gave everything out yesterday. It's the airway pharmacology one.
I think she need this specific picture.
No, I would not give a specific
Oh, I
picture.
would picture.
No. But if you,
If you want to.
oh, but they like that. They like for you to know that you don't blow into device, blow out into the air, then put your mouth on device, and then if it's a DPI, deep and fast, versus the other ones, low and deep. Okay? There's another question. It's going to come up on both of your practice TMCs. I don't have it specifically in here, but just for NBRC's sake, I want you to know, it won't be on my test. But if you are they're asked like which delivery device would be best to use on mechanical ventilation that adds little resistance and doesn't alter the delivered tidal volume. Do you know which neb is best for that? So if you're giving a patient a neb through a mechanical ventilator, which one is going to be the best one that doesn't add any extra resistance and it doesn't alter the delivered tidal volume? They'll look for you to say vibrating mesh neb. Vibrating mesh would be the Aerogen, is what you would know it as clinically.
Oh, there.
Yeah, but it's a vibrating mesh neb is what they'll look for terminology on the NBRC test. So again, it doesn't add any extra resistance through the vent and it doesn't alter the delivered tidal volume. I don't have a specific question on my test because I couldn't find one, but it will come up on both of your NBRC practice tests.
Can you repeat what it is? It doesn't increase resistance or what else?
It doesn't add any extra resistance or adds very little resistance through the circuit, through the vent, and it does not alter the delivered tidal volume. It's a vibrating mesh neb. Okay, so they're going to ask which neb, would you use that doesn't alter tidal volume or something, and then it's going to be multiple. You're going to look for the one that said vibrating mesh. Okay. All right, so that's kind of how we deliver drugs. Let's talk about the drugs. Broke it down into categories, and then we'll talk about them individually. I'm just going to give you a little brief background, but I don't think they ever really truly test on this. More, where do we get the terminology? What makes them a little different? So you have your agonist. They also call them adrenergics. They work on the sympathetic nervous system. Okay, so they are going to relax the smooth airways to move more air through them. They work on your norepi, this is FY, your norepi and your epi receptors. Okay, so they're some that it either is actively causing, bronchodilation, versus if they work on the parasympathetic nervous system, like your antagonists, they block bronchoconstriction. So you're either relaxing it or you're blocking, okay, is what you're doing depending on which nervous system you're working on. The sympathetic nervous system, your adrenergics, they're the ones that are going to try to bind to the norepi receptors to relax the airways once bronchoconstriction has already occurred, versus if it's working on the parasympathetic nervous system, like your Atrovent. What that one does is tries to block the acetylcholine receptor to prevent bronchoconstriction. Okay, this is just background knowledge to be like, okay, albuterol works a little different than Atrovent, but they're both bronchodilators. They're just working on different sympathetic nervous systems to do it a little bit differently. And then when we're talking about like those ones that work on the parasympathetic nervous system and they block anticholinergic, they're acetylcholine drugs. I keep on saying anticholinergic. They're your anticholinergic drugs. That's Atrovent. Where if we're talking about the adrenergic, this will be like albuterol. Okay? And they say muscarinic, but anticholinergic, muscarinic, they're kind of specific. They both work in the parasympathetic nervous system to block. And you know your true sympathetic nervous system and your parasympathetics, your fight or flight, your parasympathetics, your resting digest nervous systems. So if we're talking about those adrenergic ones, the ones that work on your sympathetic nervous system, actively trying to relax and relieve bronchoconstriction, we call them adrenergic. Why I throw them out like this is because when I start saying LAMA, LABA, SABA, like you'll know what I'm talking about. So SABA, short-acting beta adrenergic. Okay. LABA, long-acting beta adrenergic. Because that's how it's going to be. They'll just say SABA, LABA, LAMA. You need to know what that means. I would associate a drug with the category just to keep it straight in your head. So if I say SABA, think about your rescue inhalers. SABA would be albuterol, Xovanex. And it's coming up on the next slide. If I say LABA, long-acting beta adrenergic, think Cerebent. Okay? So just get one of them in your head. Racemics, obviously, racemic. These all work on the sympathetic nervous system. Okay, and then because we're dealing with sympathetic nervous system, they can either stimulate the alpha, the beta 1, or the beta 2 receptors. Your bronchodilators are mostly beta 2 specific. Once upon a time, they had a lot of beta 1, so there was more cardiac side effects. And then they started isolating your beta 2 a little bit more for less cardiac side effects. But your alpha, the ones that stimulate your alpha and your beta, these are the ones that are going to cause more of those cardiac side effects. Racemic being like the bigger one that we deal with nowadays. Then we're talking about our beta 2 or short-acting beta adrenergics, specific to beta 2, albuterol would be an example, or Xovanex, and then like I said, salmeterol, another name for that is Cerebent. Usually in NBC, they give you both names, so that's good. Typically, you don't have to just know one. If you know one, you usually will figure it out. Once in a while, they'll throw out just one name, and you have to, like Dornase alpha. They don't say Pulmozyme, they'll just say Dornase alpha, and then you have to know, oh, Dornase alpha is Pulmozyme. Okay, but usually, albuterol, I think, is another one. They just leave it alone. They don't give any brand names. They just keep it generic. They don't say ProAir, Ventolin. They'll just say albuterol. But I've seen it for some of the other ones, they'll give both names. Okay, so your ultra short acting, your racemic for upper airway swelling, your Kruppers, your post extubation, Strider, that's when we give racemic. Strong alpha 1 effect, so causes that vasoconstriction to take care of that swelling. Doesn't last very long, about a half hour to 2 hours. And if you ever see racemic ordered on a schedule, that's a no-no. You should be questioning that. It should only be a PRN drug. You give too much of it causes a rebound effect. So it should only be a PRN drug. SABAs, you know, albuterol, levalbuterol, which we go more with the brain, Xovanex. More targeting that beta 2, so has better bronchodilator effects. Usually lasts about 4 to 6 hours. I threw in like side effects and stuff, but I'm not testing the side effects. Biggest thing, jitteriness, right? We feel palpitations, jitteriness. We watch for an increase in heart rate. Anytime you have an increase in heart rate of greater than 20 beats on the test, they're going to want to see you stop what you're doing. Okay, just so you're aware. Any kind of side effect or a reaction, 20 beats, heart rate goes too high, respiratory rate goes too high. Like, they like to see you stop what you're doing, just so you're aware, with most adverse side effects. Okay, so those were the SABAs or short acting. Now we're going to talk about the LABAs, long acting beta adrenergic drugs. So still bronchodilators, still work in the sympathetic nervous system. They just last longer than your albuterol. Albuterol is about 4 to 6 hours. These can last anywhere from 12 hours to 24 hours. These are primarily recommended for COPD maintenance. When we talk about COPD and asthma in the next lecture, you're not going to see these recommended for your asthmatics unless they're in combination with an inhaled corticosteroid. But for COPDers, you can see them just on like a Seromed by itself. Okay, here's your other ones, Performanist, Vervona. These are twice a day because they only last for 12 hours, whereas this is your 24-hour one. Something that I take note of when I'm thinking, oh, this is an adrenergic or is this a muscarinic? Look at what they all did. TEROL, albuterol, TEROL, to kind of help you figure out what category are they in. Here are your common side effects. We know, that jittery effect, but it does have some beta 1 stimulation. Other side with hypokalemia, though I've never seen that be a big deal. If anything, I've had to give like 5 milligrams of albuterol for hyperkalemia. It has like a transient effect, but sometimes they'll make you do like a higher dose of albuterol to help bring down potassium. But someone's been on a continuous SNM, I've never paid attention to what their potassium was. Like, I don't know that that's something that specifically will monitor, see if it becomes a problem. But it is something to take note of. It does mess with your potassium at higher doses. So that was your adrenergic drugs, your SABAs, your LABAs. Now we're going to talk about anticholinergic. They call them SAMAs, LAMAs, okay? So that would be your muscarinic antagonist drugs. So they work on the parasympathetic nervous system to block constriction. All right, so I want you to know these drugs are only recommended for COPD maintenance. You're not going to see these drugs for asthmatics, at least not by themselves. Like Atrovent's a short-acting one. They will give it in combination with albuterol for asthmatics in an acute situation, but you're never going to see an asthmatic just on Atrovent. Okay. They are more specific to COPD treatment, so know that. Now they're starting to recommend it for severe asthma that don't respond to the beta agonist, but it's usually primarily for your COPDers. Like Spiriva, have you ever seen an asthmatic on Spiriva? No, that's a long-acting muscarinic antagonist, so more specific to COPDers. So here's your short-acting, your long-acting. Short-acting would be Atrovent, long-acting. Those ones, Spiriva's the one that jumps out to me that I work with the most. And there's a common theme with a lot of them. They anti-bromide. So they could be like, okay, these are going to be my SAMAs and my LAMAs. So you can kind of separate them out by category. And then we can have a combo between our muscarinic antagonists and our beta agonists. So you know the combos for, these are the short-acting ones. Combivent in MDI form, Geoneb in SVN form. These are the longer-acting ones. This is the only one of these I'm going to make you accountable because it comes up on both of your TMCs. or at least one of the team says. They like you to know about Anarol Lipta to recommend that for CPD or for maintenance. Okay? So know this. So this is a combination again of your muscarinic antagonist and your beta agonist, so the combo. These ones from here are the Alama Lava combo. Okay? These are Sama, Saba combo. So short acting, long acting. The only one I want you to know name one is Anarolipta, just because it comes up specifically on your practice test. These are also drugs, other than this, an acute exacerbation for asthma. These are drugs you're mostly going to see for your COPDers, not your asthmatics. Okay, and that's how it works. But again, I'm not testing you on that stuff, but it's trying to block binding to acetylcholine to prevent bronchoconstriction. Some things I found kind of interesting with these drug categories is that if it gets in your eyes, it can mess with your pupillary dilation, lens paralysis, increased intraocular pressure. So like those patients that you're doing a nib with Atroved and they're doing with a mask, be conscientious how much get into their eyeballs, because it can mess with their eyes a little bit. And these are some other kind of side effects that you can have then depending on delivery mechanism. Okay, inhaled corticosteroids. These are going to be first-line maintenance therapy for asthmatics. You don't normally see this recommended for your COPDers until later stages. But this is like first line for asthmatics. I want you to know that. Maintenance therapy for persistent asthma and severe COPD. And we get a little bit more into that with the next PowerPoint. We know this is they're anti-inflammatory drugs, right? Reduce airway swelling. That's really all you need to know about that. And what do we always make our patient do after they take an inhaled corticosteroid?
Wash their mouth.
Rinse their mouth out, right? It's a cause of oral fungus. Right, that. Here's some of your side effects. We prefer to do inhaled versus systemic steroids because of the side effects that go along with systemic. Here are some of your common ones. Qvar, Flovent, Omeport, Asmanex, some of the other ones there. I haven't really seen a big theme to make the word association thing. I don't see fortunately, you just kind of have to get a few of them in your brain and just know this is an inhaled corticosteroid. Ones that come up on your practice test, Asmanex comes up. I know that. Asmanex, Flovent. I think those are the two big ones they throw out. Can't remember Omeport. I know for sure Asmanex and maybe Flovent. And then you can have the combo of an inhaled corticosteroid and a LABA, so long-acting beta adrenergic. They will recommend this for asthmatics if they have nocturnal symptoms. So they're waking up in the middle of the night, their short-acting inhaler's not quite doing the trick. So they will put them on something like this for nighttime symptoms. But you're never going to see them on a LABA by themselves. They're always going to put it in conjunction with an inhaled corticosteroid. Because asthma is primarily an inflammatory disease. And then the bronchoconstriction secondary to the inflammation. Non-steroidal anti-asthma drugs. So inhaled corticosteroid is like the main go-to for asthmatics, but there are other options. So there's mast cell stabilizers, chromin, sodium, also called Intal. Who's worked with that? I feel like that one's like hit or miss. Whether people, if it's still out there, it's not a common one anymore. Antileucotrienes, they are out there. Singular, if I say singular, does that sound familiar? No? That's a common asthmatic drug they'll put them on. So if, especially for kiddos, if kiddos, got pretty decent moderate asthma going on, instead of upping their dose on inhaled corticosteroid, they'd rather put them on an antileucotriene so that they don't have to give them so much steroids. So it's usually brought in early on for kids. So what they do, these try to block inflammation. Okay, that's what they do. This one tries to stabilize your mast cells. When they get destabilized, they release histamine, leads to inflammation. But these try to block inflammation in this too. These are given in a pill form. These are given IV or like a sub-Q injection. There's one of them that's given IV form. Usually they take this like once a month. But these are prophylactic management. So this is to prevent inflammation. Like inhaled corticosteroids, it's maintenance to help treat inflammation, where this is trying to even prevent inflammation from occurring. Again, if they don't want to do a lot of steroids, especially with the kiddos, they'll put them on one of these instead. So there's your antileucotrienes. Again, the one that stands out to me is Singular. And then there's your monoclonal antibodies. Xolair is probably the more common one that I know. Okay, I'm not concerned about knowing exact mechanism of action, how it specifically works. Just know, trying to prevent inflammation and allergic reactions. Prevent bronchoconstriction, those kind of things. There are some things that might happen, adverse reactions. Okay, now we're going to get into anti-infective agents. So your inhaled antibiotics. I'll check with my notes. So pentamidine, everybody knows about pentamidine or Nebupen. We use it for pneumocystis jirovecii. It's a type of pneumonia that immunocompromised patients are more susceptible to. They like to associate with HIV patients, but other immunocompromised patients, like those going through chemotherapy, can also be susceptible to this type of pneumonia. They'll call it PCP because once upon a time it used to be called pneumocystis. Pneumocystis. Oh, I forget already. It used to not be jirovecii. It used to be pneumocystis carinii. Pneumocystis carinii used to be what it was called. Now they call it pneumocystis jirovecii. Either way, they still call it PCP, pneumocystis pneumonia. Biggest thing that you might ask about related to pentamidine is that you have to give it through this specific net, a Respigard net. Respigard 2 specifically. It's like has a filter. It looks like a Y. I can bring up a picture of it, and it has like a scavenging system and expiratory filter on one side, so that there's less of it getting in the air for those that are in the room with it. So it's one-way valve with scavenging expiratory filters. And you need to give it in a negative pressure room or a negative pressure booth to minimize exposure to whoever's delivering the med. Ribavirin, you don't see this one too much anymore, I think. I hear it's very, very expensive. I remember and it comes in these big bottles, and then you have to mix it with sterile water, sterile saline, like it comes as a dry powder, from what I remember, and you have to mix it up. They may ask about it, but it's specific to severe RSV. Okay, it's not recommended routinely anymore, but for severe life-threatening cases, they might break out the ribavirin for RSV. And it has to be given through that special type of aerosol generator called SPAC. Do we have one in the lab? Has anyone shown you the SPAC? I don't know if we have one in the lab. Looks like a big old box. Has anyone given it either of these meds before? They said they're not as commonplace anymore. Toby, this one's alive and well. No, this one for your cystic fibrosis patients that are colonized with Pseudomonas. Because they produce so much secretions, becomes like a breeding ground for bacteria to wreak havoc. One that a lot of cystic fibrosis patients get colonized with is Pseudomonas. Okay, so Toby, they'll get Toby. This one's given 28 days on, 8 days off. Okay, they go back and forth. Give it for about a month, then they're off of it for a month, back on it for a month, roughly. Caistin is another one. If they're not getting Toby, then they might get Caistin. Same cystic fibrosis patients that are colonized with Pseudomonas. That's that's what that one's for. Possible side effect of this is that it can cause bronchospasms, so they'll treat them with an albuterol net before they'll give this to the patient. Your mucolytics, I hear Swedish loves Mucomyst, Enversii does not. You ever see Mucomyst as one of the options on one of your clinicians? Don't pick it. They don't like it because of the possibility of creating bronchospasms. Even if you pair with albuterol, they just don't like it. I've seen them not want Mucomyst. Okay? And it has a long history of use despite there's no real clear indication of effectiveness for this medicine. Some places love their Mucomyst, but it's not really clear cut, like, yeah, this really does loosen secretions and get them. But still out there, alive and well, comes in 10% and 20% concentrations. Smells like rotten eggs. Because of the sulfur in there. Fun fact about though, it can also be used to treat or prevent liver damage from acetaminophen overdose.
Eucharist?
Mm-hmm. Yep. Must neutralize it. I have not looked into the mechanism and how that all works, but yeah. Side effects, rotten egg smell, that should be on there. And what was I gonna say? Oh, bronchospasms, that's the big one. Like reactivity of acetylcysteine with rubber, copper, iron, or cork. Some of this stuff's interesting. You're like, oh, didn't know that. Dornase alpha. Definitely know about Dornase alpha, also called Pulmazine. This is going to be for your specific to cystic fibrosis patients. Okay. This breaks down the viscosity and secretions for these patients. So there's an enzyme that cystic fibrosis patients are lacking. It's the DNase enzyme that your pancreas produces. So this is a genetically modified version of that enzyme that they give the cystic fibrosis patients to break down the DNA of the secretions and loosen it up. Okay, so know about that one for cystic fibrosis patient. Other mucolytic, well not, I guess they're not specifically mucolytics, but they help loosen up secretions. Blend aerosol therapy, whether that's with normal tonic, hypertonic, hypotonic. A lot of cystic fibrosis patients are on hypertonic saline. That's one usually part of their cocktail. they'll get Toby if they have Pseudomonas, they get DNase, and they get hypertonic saline. And then some kind of airway clearance, like the vest. They love the vest for cystic fibrosis patients, but don't rule out PET therapy as an option as well. But know about your different things you can do for those to retain secretions. Okay, so your hypertonic saline, your balloon aerosol therapy, and then the other ones we just talked about, the DNA cell. Not just for cystic fibrosis patients, but bronchial hygiene and clearing out secretions is also important for bronchiectasis patients. Okay, so if you have bronchiectasis patient, you have a cystic fibrosis patient, always include some airway clearance therapy for them. Aggressive pulmonary hygiene is very important for them. Okay, and the words to live by. Protect numero uno. I love the minions, they're so cute and silly. Oh man, I went too fast. It's only 9:30. Should we keep going? Well, you wanted to go before. Let's do it. Sooner we get to bingo, right? No, we just lost. Boggy. Oh, let me find it. Okay, like I said, this one is going to be kind of hand in hand with the other one for the most part. We'll do like brief reacquaint ourselves with the obstructive lung diseases. We'll do 15 minutes. Oh, you noticing how thick it is? Some of it's FYI. Okay, those are the diseases we'll talk about in all their glory. COPD. We talked about this yesterday with PFTs, but the biggest thing that separates them out from asthma is the reversibility factor. Okay, that's part of the definition of COPD. There's presence of airway obstruction that does not fully reverse with bronchodilators. The gold standard, they're the ones that decide everything COPD. Sort of a global initiative, Global Initiative for Obstructive Lung Diseases. So they're, like I said, they're the ones that decide everything that related to COPD. This is their definition. I will let you read that on your own. The two diseases that make up COPD, emphysema, chronic bronchitis. There's their definitions of what makes them emphysema versus chronic bronchitis. Told you asthma used to be part of the COPD category, and then they took it out. It's been a while, but they took it out because of the reversibility on with bronchodilators.
Can tell that in term 3 though.
I'm sorry?
Part of COPD.
I didn't hear you.
I
What?
think in term 3 respiratory is still part of COPD.
Oh, and I feel like Shane still said that, but I'm like, no, they took it out because of the reversibility factor. There is an overlap between COPD and asthma, but there is some things that separate them out. And I gave you the piece of paper with the distinction between them two. Let's see. COPD is kind of a big deal. Kills a lot of people. I mean, keeps us in business, but kills a lot of people. There are so many in this country. It's worse over in Europe where they're still smoking like fiends. Here it's more taboo. Though vaping's taken over. Like there's other stuff. There's always something that's going to be around to take over and mess up your lungs. So we're going to have good job security for a long time to come until AI takes over the world.
Right.
Yeah. Anyway. So I did not update the statistics actually, but It's now the fourth leading cause of death, and so they're, like I said, it's kind of, as the baby boomers are dying off and most people are smoking actual cigarettes, we're seeing less deaths, but it's still there. Still big. I am curious to see, like, long term, how vaping is going to, like, what vaping is going to do for people. But now, the biggest culprit is COPD, cigarette smoking, still a big culprit. And then you have the genetic form of emphysema. Everybody knows about alpha-1 antitrypsin. You've heard about it? Yeah, genetic form. If you see 30, 40, some-year-old looking like end-stage COPD, they most likely have the genetic form. I've come across 2 in my career that I can think of. You don't see them that often, but they do show up. And then here are other things that can link to COPD. Long-standing asthma, because there's a whole remodeling that happens with the airways. If you don't get your asthma under control, something we're all subjected to, right? To some extent. Those wood-burning fireplaces, so not good for your lungs. And environmental exposure. Okay, your genetic form of emphysema. So they're missing a protein. They're lacking the alpha-1 antitrypsin protein. And it leads to whole chain reaction. It's only about 2 to 3% of all COPDers are alpha-1. So that's why you don't see them that much. It's pretty under-recognized in the healthcare field. It's easily diagnosed with a blood test. You look for the serum level of that antitrypsin protein. And if it's deficient, that's kind of a big sign. And they can do IV augmentation with that protein to help slow down the progression of the disease and the destruction. Here are things you see with COPDers. And do you know why? I'll go into this after we get into asthma. No, I will say. So you know that the main problem, like what causes air inflammation for COPDs, is more due to your neutrophils, versus with your asthmatics, it's more due to your eosinophils, and that's why, like, the therapies are different for them because of what's happening and causing the inflammation in the lungs. So there's more of a neutrophil problem, where asthmatics is more an eosinophil problem. Okay, common things, we know what COPDers do. That loose productive cough, they wheeze, shortness of breath, especially when they start moving around. Later on in life, we'll start seeing it showing up as barrel chest, upper accessory muscle use, tripartite, pulmonary edema, pedal edema, or pulmonary O2 use. And again, it doesn't show up on chest x-ray till later stages. How do we treat them? Well, first you got to diagnose them. So PFTs come into play. If they're really bad, we'll do some pulmonary rehab with them so that we can get to the good level of being able to cover themselves. They'll get some bronchodilators. They'll get their LAMAs, their drugs like that. Something that comes up on your ClinSims. They love for you to recommend their yearly flu shot and pneumonia vaccines. They'd love for you to recommend those on the ClinSims. You'll get a ClinSim. It's like has to do with maintenance and like patients getting discharged or outpatient scenario, and they love for you to make sure you recommend that they get their flu shot, they get their pneumonia vaccine. Okay, recommend pulmonary rehab. Give them their bronchodilators. Give them their Spiriva. Get them as close to their baseline as possible if they get any exacerbation. And then there is an overlap, I told you, between asthma and COPD. Sometimes it's hard to tell which one it is, to do a little bit more investigating. And I want you to know for testing purposes, I've already said this before, but I'll say it again, the reversibility factor. Okay? That's the big thing that's gonna separate them out. Largely reversible airflow limitation with asthma versus COPD, largely irreversible. They may get relief from your bronchodilators, but they're never gonna go back into normal range on their 50s. And then I gave this to you just for a little FYI, to show you kind of what we're looking for to say this is most likely asthma versus this is COPD, or maybe have it overlap a little bit of both. They will stage them depending on the FEV1, or the ratio, I should say, or symptoms. Well, they rate them, they put them in a category, and that then is going to determine treatment. And that's what I want. This has changed a little bit recently, but it's still applicable. I gave you this. So take a look at it. And this is where I'm like, okay, make an association with a drug. So you're like, okay, if I'm talking about this category, this is what I'm talking about. So bronchodilators, I want you to know every COPDer, every asthmatic gets put on a PRN SABA. Okay, PRN albuterol or Xopenex. Okay? For your COPDers, they might go on a short-acting one, or maybe they'll start with a long-acting, a LABA, which would be like Cervec. So just put in your brain, be like, oh, okay, SABA, and then give yourself an example. Just so you can start getting used to your categories. LABA example that always is in my brain, Cervec, salmeterol. So that's when they're like mild emphysema, mild COPD. It's okay to throw in a bronchodilator and we'll go from there. As they get progressed, they'll add in a long-acting muscarinic antagonist, so it's like Spiriva. So kind of get in your brain an example, what is a LAMA? That's probably the biggest one you know about or care about. Spiriva, and I already told you what the LAMA is. And then common thing, for sure, if they didn't go on it then, they're gonna go on it now. Okay, at some point, all of them are gonna end up on a LAMA for COPD. And then when they're more severe, they might do the combo, the LAMA combo, which would be like Anarolithic. And then they might, if they have a high eosinophil count, you're thinking maybe there's a little bit of asthmatic components to this, then they'll introduce the inhaled corticosteroid. So a combo of this would be Advair. Okay, so just have like a drug in your brain for the category to help you just keep track. Okay, but a LABA inhaled corticosteroid combo would be like Advair. Symbicort, another one. The LABA, Anarolithic, the one that is in my brain. Okay, so just make an association. Someone say something? No. And you'll see the recommendations being different when we get into asthma. You will not see a LAMA show up. This is just a different way of looking, like how do they stage it? Okay, their QTs are in this range, then what we're gonna do, add a short-acting bronchodilator, always flu shot. When they get into this range, okay, now we're gonna add a regular treatment, could be a LABA. When they get over here, let's start thinking about this stuff. So that's how to look at that one. But everybody goes on the bronchodilator. If they're in an acute exacerbation, maybe they need an antibiotic. That's what's causing their problem. Systemic steroid like prednisone. Let's do like a little burst. Get them some O2 if they need it. Hopefully not, but we might try some BiPAP with them if they get really bad off. And worst case scenario, we need to intubate. This is for acute exacerbation. Once they get all better, let's throw them in pulmonary rehab so they can learn how to take care of themselves better, minimize those exacerbations, be more functional the day to day. And if they're still smoking, they need to quit. No insurance is going to pay for pulmonary rehab if they're still smoking. So they have to go through a smoking cessation program. Something I want you to take away from this slide, long-term oxygen therapy. This is the single one thing that seems to, let me see how I want to word it. It seems to be associated with long-term survival. It basically will give them a chance to live longer if we get oxygen on board sooner. So yeah, long-term oxygen therapy, write this down, has been shown to improve long-term survival. Long-term oxygen therapy has shown to improve long-term survival. I'm going to tell you why. Or does anyone know why? What happens with COPD is as their disease progresses, not only impacts the lungs, it also impacts the heart. So chronic, and we talk about this when we get in hemodynamics, long-term hypoxemia, long-term acidosis, a lot of things they're prone to, causes increased pulmonary vascular resistance. We learned about PVR when we talked with Josh. Yeah. So that's the resistance the right ventricle has to overcome to eject the blood to the pulmonary system. Well, if you have increased PVR, you have these like little vessels due to constriction that they have to pump the blood through. That puts a lot of strain on that right ventricle. So over time it starts failing. Okay, leads to poor pulmonale. If you can give them oxygen and keep their PO2, SaO2 in appropriate range, you're going to slow that progression of that whole chain reaction from happening. Okay, what else do I want to talk? Well, we'll finish up on COPD and go on break. So again, keeping their oxygenation in a good steady place will help slow down that process of, messing with the heart. Okay, some patients might qualify for lung transplant or lung volume rejection. Get rid of that disease portion that's like, what's the word I'm using? And kind of bring it down for the rest of the lungs. Get rid of it. And then if it is related to the genetic form, let's give them that protein that they're missing. Let's do this lecture break, then we'll go on break, and then we'll talk about asthma. Break out in your little groups, however you want to divide yourselves up. Talk about this for 5 minutes, and then we'll go to break, okay? Won't get in the way people reading. Shh, yes, I'm reading. Don't be such a bubble.
She's like, are you gonna turn around? No, I did not.
Hello. Did you get to it? 7-year-old male, long-standing COPD, admitted to the hospital with acute exacerbation. When we examine him, he's not dehydrated. He has diminished breath sounds without wheezing, and there's his lab values. Why do you think they told you that he was not dehydrated? What is it? Which value there is irrelevant to? That is the inhibition. The hematocrit is influenced by hydration status. So he's not dehydrated, so that's not the reason this is high. So what could be the reason?
He's chronically low on O2.
Exactly, chronically hypoxemic. Okay, so that was the first clue. And then what is this ABG? Let's interpret it. Say it again. Respiratory acidosis.
Yeah.
And this is what we would call acute on chronic. Acute respiratory acidosis on top of a chronic one. How do I know it's chronic? That ICAR's in the 30s. So his CO2 is usually on the higher end, but this is too low of a pH. It should be closer to normal, 7.34, 7.35. So to know about asthma, it's primary, and I said it already, but it's primarily an inflammatory disease. That's their main problem. Airway inflammation. So you're going to see as maintenance therapy, they're going to start inhaled corticosteroids right away. Okay. Lots of people out there with asthma. It's going to be more and more prevalent. People do die from asthma. So we want to take it seriously. Yeah, people die from asthma. There's some people that are genetically more susceptible. You know, we hear there's like a big association between asthma and allergies, right? Eczema too, the trifecta. Usually asthmatics will have allergies and a lot of times eczema too. What I was gonna say, and there's different things that trigger their asthma. Biggest thing with asthmatics is like knowing your triggers and avoiding them, or knowing how to control them if you can. So knowing what you're allergic to and avoiding it. Some people only get exacerbation if they get like an infection, respiratory infection. Right. So like that's when mine gets triggered usually. So if I have a cold, it's the way it is for my son too. But there's other things. So there's certain things that they're exposed to with their job or with environment, but knowing those things and trying to avoid them. Exercise, some people it's just exercise induced, some it's they're breathing cold, dry air around cigarettes. And there's different things that can trigger it. But there is like a genetic component to it that make people more susceptible compared to others. Let's see, what does it say? How do we diagnose it? History. A lot of doctors, if it's walking and talking like asthma, they just assume and then they put them on, a bronchodilator. Sometimes they miss stuff and they misdiagnose it. So I say it would be good to have some like PFTs when somebody gets a little older. When they're really little, obviously, that's not the route we go. But at some point, it would be nice to have a formal diagnosis with looking at their PFTs and that airway reversibility.
Typically, what age is a PFT, like 34?
I think it depends on the child and respiratory level. I've done them as early as 6 years old and gotten some decent stuff. Then there's I've gotten like 9-year-olds that have given me crap, so But the earliest about somewhere around 6, they might give it a try.
Okay.
Yeah. That reminds me, was it a methacholine challenge or was it a PFT? It might have just been a PFT. And I think she was about 6, 7 or 8 now. And whenever when we were doing the net, she'd want to like close the door and then she'd do this to me. She's like, I'm watching. And the mom's like, oh, her and her brother do that. But I will always remember a little girl just standing there with her neb doing this to me. It was hysterical. Okay, so PFTs. If something's walking and talking like asthma, we're not quite sure, we'll do a bronchoprovocation. Also called inhalation challenge, bronchial challenge, methacholine challenge, okay? So PFTs are normal. You're not capturing it on PFTs, but the symptoms seem asthma related. They're just not having any problems right now, because when they're not having any problems, their PFTs can be completely normal. So we'll do a bronchoprovocation, trying to induce asthma-like symptoms to capture it, to diagnose it. Oh, ABGs, if you get someone in acute asthma attack, usually they start off alkalotic, they're hyperventilating, and then as they tire, they go acidotic, just so you're aware. Another valuable test for diagnosing asthma, exhaled nitric oxide, which we talked about yesterday, FeNO, fraction of expired nitric oxide. If it's elevated, that equates to increased airway inflammation and uncontrolled asthma. So it's kind of a way they can look to see how controlled their asthma is. Like, okay, let's put them on inhaled corticosteroid. let's do the pheno test again and see if their numbers have come down and improved. Okay? I want you to know this slide. Like, what are we looking for to help with the diagnosis of asthma? And then it also determines severity and treatment options. So are they coughing, wheezing? Some asthmatics are just coughers. They don't wheeze. I'm a cougher. So is my son. We don't wheeze. Are they waking up in the middle of the night because their asthma's bothering them? When they're out like exercising, is it worse? How often are they using their rescue inhaler? That determines how controlled. If they're puffing away on their albuterol all the time, they're not well controlled. They need an inhaled corticosteroid. Because they're stressing the bronchoconstriction, but they're not addressing the inflammation, which is the primary problem with asthma. How often are they having exacerbation and missing school, work, and then what are their PFTs? So they look at all these things to kind of determine the severity of their asthma, to determine what the treatment option is. So based on that step, then we'll put them in a category or step. Step 1, intermittent, they're not really having too many symptoms. Let's just give them a pure albuterol and just keep an eye on it. Step 2, once they become mild persistent, I want you to know this, once they become mild to moderate persistent, this is where we start adding an inhaled corticosteroid. Pure albuterol alone is not enough. They need something for maintenance, something that they take every day that needs to build up in their system to keep their asthma under better control.
That's when we start adding the what?
Inhaled corticosteroid, when they become mild to moderate persistent. So they're having symptoms pretty regularly. Then give them a steroid, Flovent, Q-Bar, Osmonex, one of those. And then from there, there'll be other things I'll add. I gave you this in the handout, and then I also gave you another handout with the treatment options, which will come up at some point. All right, here are our goals. We want everybody to be functional, no limitations, not missing a bunch of school and work, those kind of things. Oh, the end all say all for asthma, like gold was for COPD, it's the NAEP, National Asthma Education Program. Okay, if you see the NAEP, you'll know that's related to asthma. This is what we're trying to achieve in saying that the asthma is well controlled. They're not having a bunch of symptoms, they're not having exacerbations, they don't need to be using their albuterol very often, no limitations, PFTs, no limitations. As with COPDers, all asthmatics get put on a bronchodilator, okay, a SABA. Once they become mild to moderate persistent, we're going to add an inhaled corticosteroid. Okay, so do know that. We might, if albuterol alone's not cutting it, we might add some Atrovent in there. So we will put an anticholinergic in there in combination with beta agonist or adrenergic. We're not going to just give it alone. And then the anti-IgE therapy, so your anti-leukotrienes, your monoclonal antibodies, they might start thinking about including those too for their maintenance. If their steroids aren't cutting it, or with little kiddos, if they don't want to put them on a bunch of steroids, then they might start adding that therapy in. So singular, one of the main ones, but Oculate, Zyflow are also options. We kind of talked about what they do, how they work, their prophylactic management for asthma. And then here's how they recommend, if they're in this step, the steps from before, based off of severity, this is the treatment recommendation. I gave this to you in your handout. So again, step 1, they're only having problems every once in a while, maybe when they get a cold or they exercise. Let's just give them a pure and SABA. Step 2, when they're mild, persistent, they're having symptoms on a regular basis, let's give them an inhaled corticosteroid And then we might start thinking about some of these other things, chromoline sodium, leukotrienes, theophylline. These, I don't know how much they're used nowadays. How many people see theophylline? Maybe Nikki more, it's a stimulant, you can use it like caffeine for babies. But you don't see it. I'm actually allergic to this. It threw me in the hospital when I was 8 years old. And I had to drink liquid charcoal. It was not fun. Because I was having like palpitations and all kinds of issues.
You said, I'm sorry, you said they give caffeine instead of that now?
No, say like if you're gonna see it anywhere, it would be in the NICU.
Oh,
I would say they would use this theophylline as a stimulant or caffeine,
Yeah.
just to stimulate the babies,
Okay.
keep them from going apneic. I don't know that it's used so much with asthmatics, but it's still in there. Step 3, when they're moderate persistent, then look what we're gonna do. You're gonna start with a LABA. Okay, so Advair. But do you notice you're never gonna give the LABA by itself? With COPDers, they'll give it by itself, but with asthmatics, it always has to be in conjunction with corticosteroid. There's an increased incidence of death with asthmatics, so they're just getting a LABA. I think they get a false sense that they're taking care of their asthma and they're not addressing inflammation. So bigger chance of them getting into life-threatening crisis. So, and then so forth, so on. But you notice steroids are added early on and they are always recommended. If they happen to end up in the hospital, we will give them the beta to agonist, adrenergic, however you want to say it. Now, on your clin stims, specifically, I remember one in the final exam where you had an asthmatic in the ER, and I think they gave you peak flow measurements, and it shows slight improvement. You started off giving them like an albuterol treatment, and you saw slight improvement, and there was a choice to give another albuterol or Duonet. Don't be afraid to do 3 back-to-back-to-back NEPs with asthmatics. That's how they treat them in ER. Either you throw them on a continuous for an hour, or you do back-to-back-to-back. And there is a clin stim that is going to make you do back-to-back-to-back treatments. Don't feel like you're giving too much or that's not the right answer, because that is the treatment. All right? And also IV steroids. They will want you to recommend IV steroids, Solu-Medrol, for your acute asthma attack. That comes up on a clin sim as well. Oxygen, of course. If they're really struggling, they might do Heliox. If it's related to infection, antibiotics. Magnesium, because it does have bronchodilative properties. And then worst case scenario, they end up on the ventilator. There's something called bronchial thermoplasty. This is, they put a probe into the central airways with a bronch. This is more dry. And then what it does is provides heat in the form of radio frequency waves, and then it decreases the airway smooth muscle mass. So kind of prevent bronchial constriction. Says improves asthma-specific quality of life, reduces severe exacerbations, and it can last for up to 5 years. So, kind of cool. It was approved by the FDA in 2010, so it's been out for a little bit. Immunotherapy, allergy shots, not usually the standard with asthma treatment. It's more for like allergic rhinitis is more what it's used for. Shows some promising effects for asthmatics, but only if they have allergic asthma. Biggest thing with asthmatics, environmental control, and I want you to know about environmental control. Know your triggers and try to avoid them. Or manage them. Okay, if you know you're allergic to cats, don't go having 5 cats in your house. Just saying. Education, this is a big one that comes up on under CTEF too. We want repeat demonstration. We want them to show us that they know how to do their peak flow. We want them to show us that they know how to do their MDI. We want them to show us they understand their asthma action plan, okay? So repeat demonstration. And as far as peak flow goes, we're gonna recommend daily peak flow monitoring for our moderate to severe asthmatics. So write that down. Daily peak flow monitoring is recommended for moderate to severe asthmatics. And I want you to know about your peak flow zones. So let me put them on the board. So what they'll do is when they are at their baseline, their asthma is well controlled, they will have them do their peak flow measurements for 2 to 3 weeks, a few times a day to kind of see what's their personal best. And then their zones are based off of their personal best. So green zone, pluses, those go. This is when they're within 80 to 100% of their personal best. Okay? So whatever you're doing for your asthma action plan, keep doing it. It's working. Yellow zone. Guess we could technically say 60 to 79%, but. Okay, something's changed. Your asthma's not as controlled. Maybe we need to do something different. Maybe you need to do an extra albuterol inhaler to recess your peak flow in 20 minutes. Maybe if you have acute infection, let's throw you on an antibiotic. Or do a prednisone burst. So they have to do something different than what they're doing, depending on what the situation is per their asthma action plan when they're in yellow zone. Red zone, less than 60% of their personal best. We're not messing around. You need to seek some kind of medical attention. Okay, go to urgent care, go to the ER. So once you're in the red zone, because remember, people die from asthma. So they don't want you to try to figure it out on your own when you're that bad. Go see your doctor, go seek medical attention, okay? So know about your zones and what we should be doing when we get to a certain zone. I get through a lecture too quick with you guys. You're all quiet. I like that you're all listening. You're quiet though. So it's hard for me to tell, are you getting it? Please ask questions if you need to, or if you need to. You have one? Come on, please ask me something. No. Oh, and then there's special considerations. There's, depending on what's triggering their asthma. Some people it's just exercise. Some people something they're exposed to. Some people just cough. We talked about this already. Some people it's worse at night. If they're worse at night, then we're going to do inhale corticosteroid and a LABA combo, like Advair, right? Give them a LABA. Some people it's worth at night just because changing how they're positioning, how they're laying. Reflux has something to do with it for some people too. It's not the word I was looking for, but has an association. Asthma said some asthmatics, a pretty good amount, 5%, have an allergy to aspirin. And then for pregos, some of them get scared to take their asthma medicine. They're like, oh, it's gonna hurt the baby. It's actually gonna hurt you more if you don't take your asthma medicine, because a lot of them are shown to be safe, so you should be taking your medicine unless otherwise told by your doc. GERD, there's like I said, association between sinusitis, GERD, asthma. Did you know the 3 major culprits of a chronic cough? And just said them if you're listening to me. What was I saying, Sean? Play that back.
I don't know how to work that thing.
No, I was like, don't touch it.
Oh.
Scary. Asthma, reflux, and postnasal drip. I said sinusitis. Postnasal drip. Those are the big three culprits of a chronic cough. That's more FYI, but like if someone's like, oh, I have this cough, those are the three things they're going to work them up for right away. Asthma, reflux, and postnasal drip. There's like an association between, just like asthma, allergies, and eczema. There's an association. Lecture break. Get into different groups this time. Come on. Pretend you like somebody new. So what, I heard different people talking about like severity. What did your group come up with? Moderate, yeah, moderately persistent. Okay, moderately persistent. She's got to use her Sawa daily, which is never a good thing. She's waking up a couple times a week, short of breath. She's got to go to the ER a couple times. So she's moderately persistent at this point with mild airflow obstruction. We want to be exact. So knowing that about her, what do you think she should go on? Someone in the middle.
I said a lot of for steroids.
Yeah, she should have an inhaled corticosteroid LABA combination.
Yeah.
So for sure inhaled corticosteroids. Once they become persistent, steroid. And then because she's having nocturnal symptoms, we should also put her on a LABA. So maybe Advair or Symbicort. Okay. If she was already on that and it wasn't quite cutting it, what could we think about giving her in addition to somewhere in this group? What do you think? So if she was getting like Advair or Symbicort already, still having problems, or as an alternative, what do you think we could do instead?
You like salbutamol or something?
Salbutamol because she was an acute exacerbation, like a
If you're already giving her
so you're already giving her an inhaled corticosteroid and a LABA.
LABA, then you. I mean, you've given those. That's right. So a higher dose.
We could do higher dose, or we could do. I said there was a category of drugs that we would do prophylactic management, anti-leukotrienes. So like Singulair. Okay. Yeah. So don't forget that they are an option, or anti-leukotrienes. If say we're already on inhaled corticosteroids, not quite cutting it, we can either go up on the dose on or an inhaled corticosteroid, or we can consider adding a leukotriene, like Singulair, okay?
Okay.
And there is a TMC question, I think it's on the second one, related to that, adding an anti-leukotriene. Or they may say a leukotriene modifier. See the word leukotriene, think of some. Questions? Okay, now let's talk about bronchiectasis. So abnormal irreversible dilation of your bronchi causes chronic air inflammation, destruction, takes on different shapes. Recurrent pneumonias can lead to this. Foreign body obstruction, make a tumor. There's different things that could lead to it. What's studying? There's some autoimmune diseases. Rheumatoid arthritis, Sjogren's, which I have. And if they've had like childhood diseases like whooping cough, measles, it can lead to bronchiectasis. That's something. Here's the different shapes it can take on. There's your normal, and then that's what happens. And because of how they become permanently dilated, guess where secretions like to start hanging out in there and you can't get them out. So good pulmonary hygiene is very important for these people, just like with their cystic fibrosis patients. And a good amount of cystic fibrosis patients will end up with bronchiectasis too. Okay. For proper diagnosis, usually they have to do a CT scan. But what I want you to know most about bronchiectasis as RTs, bronchopulmonary. Vest, PET, acapella, get them on airway clearance drugs, if you want to call them drugs, like aerosol therapy, hypertonic saline, those kind of things. Get those secretions out. There's going to be an MBRC question on the first team C. It says that the patient was doing postural drainage and it was ineffective for preventing exacerbations. What would you consider now the best? Do chest wall oscillation was one of the options, and that was the option. Maybe if PEP was an option, that could have been, you would have considered it, but of the options that were given, the best was the answer. But they'll say HFCWO, high frequency chest wall oscillation. They won't say the best. Cystic fibrosis, we know it as a genetic disease. For a child to be born with cystic fibrosis, both parents have to be carriers, and then there's a 1 in 4 chance that the child will come out with cystic fibrosis. And they're lacking a protein, that's CFTR protein. It messes with a lot of different systems, like their pancreas, their reproductive system, their lung, respiratory systems. It messes with a lot of different organ systems. We know how we diagnose it with the sweat fluoride test. Remember, if someone already has cystic fibrosis, like on your ClinSims, don't ever pick sweat fluoride test. It's only if we suspect it. But if first already they tell you they have cystic fibrosis, don't pick it as an option. Oh, what do I want to say about that? All kinds of stuff goes on. Digestion. They have a hard time digesting. Like they don't absorb nutrients, minerals very well. These poor kiddos. So they end up with diarrhea, they're malnourished, okay, oily, smelly stool. But what really gets them in those secretions, their pulmonary system, it starts failing on them because they just can't deal with all those secretions, breeding ground for a bunch of infection. A lot of them get colonized with Pseudomonas, MRSA, there's another one, Burkholderia septicemia, so a bunch of different bacteria they end up with. And stage, they look like COPDers, the barrel chest, they end up with pulmonary hypertension, pulmonal. Yeah, they end up presenting like COPDers. They end up also being at increased risk of diabetes, again, because the pancreas isn't working the way it should. All kinds of stuff goes on with cystic fibrosis. Biggest thing with us as RTs is getting those secretions out, right? Good pulmonary hygiene. But they'll also get pancreatic enzyme support and vitamin supplements because they don't absorb those things very well. Good CPT, okay, PEP therapy, those kind of things. DNAs break down the viscosity of the secretions, also called coenzyme. Hypertonic saline. They might have to go on Toby or Cayston if they have Pseudomonas. Those are specific to Pseudomonas. And then other things that they might need, bronchodilators, maybe, if they're lucky, if they're good candidates for it, lung transplant. But know about treatment regimen, know about your pulmozyme. There's a question on the TMC tests related to they're on this, and this, what's missing. Pulmozyme was the answer. Toby for Pseudomonas. It reduces the incidence of bronchiectatic exacerbations. So when CF was first described in 1938, children were only living to about 6 months of life. Now, the median age of survival is 59 years. So they've come a long way in taking care of cystic fibrosis patients. All right, as RTs with our CBA patients, part of us diagnostic and therapeutic interventions for them. Okay, answer this question and then